A very special treat this morning. Dr. Sandra Billinger is here to give us a talk. Dr. Billinger is a proud graduate of KU Medical Center, where she did her master's in physical therapy and her PhD in rehabilitation science. She started her career here as a director of she didn't start her career here as a director, but she became director of the Reach Laboratory and has joint appointments in neurology, physiatry, and of course physical therapy. She's had many honors and awards, which include the Faculty Investigator Research Award, the Stata Norton Distinguished Teaching Award, and the Chancellor's Distinguished Teaching Award, and was named the Interim Associate Dean of Research last year. So we're really honored to have her give us a talk on exercise, its medicine for stroke recovery. So thanks, Sandy.
Yeah. So thank you, everyone, for coming. I tend to be a little more informal in my presentation, so for those that are incoming DPT students, I tend to like to have discussion. So how many residents are in the room? Good. I'll be expecting some. So I am going to be talking about exercise as medicine, and I think this is a topic that is so near and dear to my heart, and I'm very passionate about it. It's one of those topics that we all know that exercise is good for us. It's well known and well documented, but I think as healthcare professionals, what are we going to do about it? And that's the challenge that I have for you today. Is I want you, as I'm going through my slides, to really think about it. I'm going to present some other information from a PT perspective and what we see as the barriers for exercise. And that's hopefully where I would really love to have some discussion about how we can influence practice or what we could change in our patients when we think about stroke recovery. So I did want to disclose I do have funding through NIH and also the American Heart Association. And then these are the objectives that are written down and that you can evaluate me on. So just to kind of give you an introduction, we have this global problem. Our non-communicable diseases, or NCDs, they account for about 70% of all deaths worldwide. So looking at heart disease, stroke, cancer, diabetes, and lung disease. And I linked this, what's good for the heart is good for the brain. And hopefully as we're going through this, you can think about, blood pressure, cholesterol, heart disease, and how that affects the brain. And mostly thinking about that vascular system and regulation. So these are some quotes that have been in the literature. And when we think about this, we're not just talking that, physical inactivity is a problem. They're now calling it a pandemic. That being inactive, not following a healthy lifestyle, not doing things that are good for heart health is going to eventually lead to things with the brain. And we'll talk a little bit about that later. And probably my favorite is stemming the global tsunami. When we think about a tsunami and what that means for populations, or we think about how that happens to the coastal cities, I think that's pretty impactful. And it really is something, again, I challenge you to think about how we can try to implement physical activity in our patients. This is also a favorite quote that I use a lot when I give presentations. And if you think about this, if you could take every benefit that exercise has, and you could put it in a pill, it would be, by physicians, the single most prescribed medication today. Think about the profound implications of that, the most beneficial medication. Now, I have had some physicians say, if I could just invent a pill, and I call it aerobics, with an X at the end, and we could give it to people. I don't know how you take all of those pathways and all the benefits and package it. Somebody will try, and I'm sure people are working on it. But really, exercise is one of the best things that we can do. Again, I love this cartoon, the exercise pill. I'm not sure that he actually has a pill, but really to treat your blood pressure, dyslipidemia, osteoporosis, reduce your risk of cancer, everything you can have. Take your pill, take it out for a bike ride, take it for a walk. All of that is really important. I love, some of the things that people are really trying to be creative with. The Vermont governor, I think, had started this initiative, and that, physicians, you are really powerful in our healthcare system. For you to write that prescription, the patients really look to you and our healthcare system, our healthcare professionals to say, you need to do this. A lot of patients, of our patients that we see don't know what to do. And so they need something written down, something to tell them what to do for exercise. I see a lot of people that I'm not really sure, and I'm not suggesting nobody does high intensity interval training, but sometimes I'm wondering, is that the best medicine? people just read things. I had a patient one time, she was 32, that had a stroke, and I was talking to her because I wanted to enroll her in a study, and she's like, well, this all happened because of exercise. Oh, wait a minute, what do you mean you've had a stroke because of exercise? Well, she was on birth control pill, had high blood pressure, was overweight to obese, had high cholesterol, was in the early stage of type 2 diabetes, and she exercised and she started taking these pills so that she could lose weight and really boost her metabolism, and ended up with all of those complications, having a stroke. So I had explained to her that it really wasn't the exercise piece. But again, she just didn't know. Her doctor told her to lose weight, and so she read things on the internet. So again, it's healthcare professionals, we really need to take the time to prescribe exercise and tell our patients what they need to do. There's also this very large meta-analysis. If you haven't read it, I really encourage you to do that. They looked at the benefits of medicine, exercise as medicine for people after stroke, and they looked at a lot of other chronic conditions, but I'm just going to highlight stroke because that's what we're here for today. But when they looked at the outcome measures, mortality, exercise was more effective for treatment than antiplatelets, anticoagulants. And I'm never suggesting that exercise should ever replace what we think is good for our patients as far as medicines, but that we could certainly prescribe exercise alongside and really encourage our patients to engage in physical activity. So, in 2003, 2004, there was a physical activity and exercise recommendations that came out for stroke survivors. And it had been a long time since then it had been updated. And one of the things that I was really pushing the American Heart Association on is, we need to update this. There's been so much literature that has come out since that we really needed to update this. Most of and it's still an issue for today, is that most of these recommendations are based on older adults, not necessarily what we know about stroke, because that is so new. When I started working in the field of exercise and stroke, late 90s, and we still thought exercise was bad for stroke survivors, that it would create more problems with spasticity or tone. So we've come a long way with the literature and what we know about physical activity or stroke, but we still have a ways to go. But what we found, again, is recommendations for the general population fit for those with heart disease, because a lot of our patients have those comorbidities of high blood pressure, high cholesterol, physically inactive or sedentary behaviors, at risk, maybe overweight or obese, and then, with diabetes. And so again, making these general recommendations. We talk about how, just even telling your patients to walk, to be physically active, to go out for a walk during their day, to get up. And quite frankly, sometimes that message can be as simply as sit less. Just sit less. Try to get up out of your chair. Try to, take 3 or 4 walks. Or if you're going to go get something out of the refrigerator, try to make several loops around, or try to do more things at once. And so, again, we have exercise prescription in there, but this is a really important document. We talked about a lot of benefits for cognition, for heart health, and certainly the benefits of reducing secondary stroke is really important. So I'd like to spend a little bit of time talking about the challenges with exercise post-stroke, because I think it's important to understand what some of these barriers are. And I really would encourage us to open our minds and think about exercise as medicine, and think about it as filling out a prescription pad. And I think the questions that we all have for our stroke patients is, how often do we tell them to take this exercise pill or this medicine? How much do we really need to prescribe? And that's looking at intensity. Again, there's a lot of literature that suggests high intensity. Well, how's the stroke survivor going to know what to do? Should they just walk? Should they do moderate intensity? And again, we need to guide them on what that exercise dose is. How many times per day should this medicine be taken? Again, is your prescription just to get up and down and to move around, and then it should be often? Should they do a certain amount or a certain time throughout the day? Should it be once per day, 3 times per week, 5 days per week? So again, we really need to encourage them. And then what type of medicine should they take? And when we think about this, should they be doing aerobic activity? Should they be strengthening? Should they do stretching and flexibility, yoga, tai chi? Should they be on a bike, a recumbent stepper, a treadmill? What do we really want for them? And again, we have to be very specific, because telling our patients just you need to exercise more doesn't really help. You have to have the conversation. And this follows, if you're an exercise physiologist or in your bachelor's you went through and had information on exercise physiology, it's essentially the FIT principle when we think about, frequency, intensity, time, and type. But when I give the talk to healthcare professionals, I kind of put it in a way of a prescription. And when you think about writing out your dosages, it's the same for exercise. People need to know how much to take. And I think the same goes for physical therapists and other healthcare professionals. We need to do a better job, especially when we do transitions of care. Transitioning out of therapy and into the community is really important. So utilization of aerobic exercise. And I think this comes from 2 groups of physical therapy groups. And so we know aerobic exercise is very much underutilized in neuro rehab. A lot of times I'll talk to therapists and I'll say, do you do exercise for your patients? And they'll say, yeah, we get them on the new step, or and a lot of times they'll use this device, which is a recumbent stepper. It's really easy for stroke patients to use. Their good side can help propel the bad. They sit in a chair and step back and forth. Excuse me. And a lot of times they'll do it with a warm-up, and I challenge them and I say, well, why don't you prescribe exercise? Why don't you have them keep it at a certain watts? Make sure their heart rate gets up, or that they're breathing harder than just they're talking and they're looking, and all of a sudden they stop and they're looking around, and again, we've seen this all. They tend to be distracted. So in 2013, Marilyn McKay Lyons, she's very aggressive on physical activity. She's a physio in Canada. And they did this study. And then in 2017, I collaborated with Pierce Boyne and a group at University of Cincinnati. And we also worked with Marilyn on this, and we did some surveys. And we looked at utilization and really asked therapists, neuro rehab therapists, all about exercise, so we could really get a better understanding of this. And it was really interesting because these 2 points came out in both studies, almost identically for the percentage. And that almost everybody agreed that physical activity is good for our stroke patients. 77% said they prescribed exercise in some way, shape, or form. We didn't get into the nitty-gritty of the FIT principle, but they did exercise. The majority of the patients used the health record or patient response. So there was no objective measure of where to start or how to do it, but just used that as a guide. And 2% used an exercise test to guide prescription. And so some of this is, there's a group of us that are really advocating for objective measures, looking at ways, whether you do a 6-minute walk test, whether you do a submaximal exercise test. and, or how that, how you would prescribe that, to do that test so that you could most accurately prescribe medication. Or I'm sorry, physical activity. So when we think about doing a submaximal test in rehab or maybe an outpatient, what do you think the most common response I get is? And this is where you guys have to chime in. Anybody? No? So like a submaximal exercise test, what do you think the biggest barriers that I often hear or the most often comments are? Somebody's got to guess. Anybody?
They don't have time to do it.
They don't have time to do it. Very good. And what else? Anything else?
They need help to walk, so they can't do it on their own.
Okay, so they can't do it on their own. So one of the things, and those are all correct. That's exactly what I hear. I don't have the equipment is the other one. I don't have the equipment. I don't have the time. And I really don't know what to do. And so I always tell people, if you have barriers with the 6-minute walk, because most people know how to do that. If they can't walk, I won't spend a lot of time talking about this, but we developed a submaximal exercise test that with Dr. Varday's help, and I'll talk a little bit about it later, but that we tested this in inpatient rehab. And so my argument for time is that's not an excuse. If you're willing to do a 6-minute walk test, most of the stroke patients don't go beyond 6 minutes on my submax test on this that we developed. And so again, time shouldn't be a barrier for that. You just have to get them set up, and we'll talk a little bit about that. But these were the barriers that were reported in the manuscript by the Canadian group, and that was, the patient was nervous. We asked about patient responses. They were fearful that they had cardiac issues or blood pressure. They had some. The physical therapist had patient concerns about cardiac issues. Then there's always the cognitive function. If they can't follow directions, it's really hard to have them do some type of standardized test. And that they always report fatigue, and that's not uncommon post-stroke at all. There's a lot of post-stroke fatigue. But again, you're looking at what the patient can do, and I encourage you to think about that. You're looking at what your patient can do, and fatigue is part of that. If they're tired, they're going to have a short test. That doesn't mean we shouldn't test it, because I think that's really important to measure. And then environment, lack of staff, lack of time, unsure of the screening protocols, and really unsure of how to prescribe exercise. And again, it depends on how much they get in school or in training. I know there's a lot of people who are wanting to push more exercise prescription into the physical therapy curriculum. And then I work with a lot of physicians who are trying to push exercise as medicine into the medical school curriculum, and how do we integrate that? And for any of the incoming DPT students in the room, you get plenty of exercise prescription, trust me. With the U.S. group, it was very heavily weighted on lack of time and lack of equipment. So these were a little bit of differences between the U.S. and Canadian. But again, the same concerns for the patient, about their patients. There's cardiac, they're not sure what to do with the uncontrolled cardiac issues. Cognitively, if they can't follow directions, and again, that person's not appropriate, but then certainly thinking about fatigue. For me, this was really important and shame on the researchers for this. We're not reporting everything in a standardized way, and I'd like to see this get changed. In 37 randomized trials in subacute and chronic stroke, there was lack of consistent reporting on the FIT principle. So if we're not reporting what we're doing, how are therapists, physicians, how are they supposed to know? How do we disseminate that information? In clinical drug trials, all that information is very clearly outlined so that you know what the dose was, comparing 12 milligrams to 5, maybe times per day. It's always very clear. So there's this lack of consistent reporting. And for me, intensity is probably one of the most important factors. We want people to do it daily. We want people to engage in physical activity. But if we think about what exercise intensity does, intensity drives cardiovascular change. There's certainly nothing wrong with walking for your health, making sure you're getting your adequate steps. But if you want to see reductions in blood pressure, reductions in cholesterol, and weight loss, you have to really be in that 50 to 75% of heart rate reserve for the cardiovascular benefit to see reductions in blood pressure. Again, that doesn't mean lower intensities aren't beneficial for overall good health. It's just intensity will drive this. And then, obviously the higher you go, there are other risks with high intensity exercise, but that you also, sometimes we see the greatest reductions in blood pressure, not necessarily the greatest in weight loss in the literature, but certainly blood pressure and cholesterol. This was one of the reasons I put in a grant to the NIH StrokeNet. There's a network all across the United States that has multiple sites across the country. If you didn't know it, we're a spoke of the Minnesota site. And so I put in a grant. Didn't get funded on this first round. I'm thinking about how to revise it. And the reviewers, there was an issue surrounding intensity and why did you pick this? And some of it was generated out of, if it really drives cardiovascular health and benefits for endurance, why wouldn't we look at intensity? So I need to think about that a little bit. But it is the most underreported, and I think we need to know, what is really important for stroke patients. Do they adhere to 40% to that low intensity? Do they do it more often? Will they be more active when they go home? If they're going to do it, maybe that's the better dose. I think that's a good question. Do we stay in that moderate intensity where, again, they may have some benefits, maybe they can't keep that intensity up the whole time, but do they get some benefit? And then we have a higher intensity group. It's not defined as truly as high, above 85% of your heart rate reserve, because I don't know that we could get them there consistently. But looking at another group and seeing how their adherence is and what benefits they get out of that on walking. So stay tuned for that. Hopefully we could get funded on that. But I think intensity is really important for us to understand the benefits of that. So I'd like to take you through getting started. And again, I really wanted to focus on this because I think it's important for you as healthcare professionals and for all of us to think about how do we implement this? How can we be creative in trying to think about ways in which we can implement this? And one of the reasons I wanted to share this with you is that there are places across the U.S. I just had an invitation from UT Southwestern. People really are picking up on this idea of exercise as medicine for stroke recovery. UT Southwestern in their PT program, in their PT department, they want to prescribe exercise. They're using the HA recommendations that I showed you. They've contacted me to be a consultant on their project. But they are really looking at aerobic exercise and how they can use that to benefit stroke recovery. There's also a group in New York that have really been implementing our submaximal exercise test, and we'll talk about that here in a little bit. And they've had some really great questions about what the exercise test means and what they're getting, the values, and how they can use that to prescribe exercise. And they're like, well, we're not getting really the gains that we want from our exercise program. And I said, you had a 10% increase in their VO2. Like that's their estimated VO2. That's what people get in older adults. And if you can improve their VO2 by 10%, you're actually doing really well. And they were very happy to hear that. And I think our inpatient rehab is really a great place in which we can do that and think about it. So, you don't have to necessarily use this sheet, but we do kind of think about, for people with stroke, I know it's hard to see, but what we have up here is looking at, do they have known cardiovascular, pulmonary, or any metabolic disease? And it lists it over here. Well, they've already had a stroke, so that automatically puts them in the high-risk category. And it just means we need to be thoughtful about all their comorbid conditions and thinking about this. But I also, in our lab, when we use this, and we use this on the inpatient unit, we want to know, do they have any other symptoms that we need to, look out for? Do they have unusual shortness of breath? Do they have, tachycardia? Do they have PVCs? But then looking at their risk factors too, I think this is important to understand. So we like to see people characterize them just to be aware of what their risk is. So for screening, so we talk about this in the AHA physical activity and exercise recommendations, but also I mentioned Dr. Marilyn McKay Lyons a little bit a while ago when she did the survey of the physical therapists. We came together in Canada and put together these recommendations, and I really encourage you, I provided the links on the sheet for the aerobics physical activity, and these are best practice recommendations, and they're very clinically centered to like making decisions clinically on what to do. So if you're interested, I'd encourage you to look that up. We really, before we start exercise, we want them to be neurologically stable. That's really important, especially if you're looking at the acute period. And then we want their cardiopulmonary, we want that blood pressure under control to some degree, and considering that hemodynamic response. We now know that through Julie Bernhardt's work and her multi-center, multi-country trial, we still believe that out-of-bed activity is very important post-stroke. Staying in bed is not good. Getting out of bed is important. And then looking at, but not prior to 24 hours. There's no need to start that super early intervention, intensive intervention. But again, within that 24 hours, getting them out of bed, as long as there's not any contraindications from physicians on that. But we do need to look at getting them out of bed. So I want to talk a little bit about our exercise test. Yes?
On that, what level of stroke, it gives me a little angst to see that just in the way sometimes people might interpret that don't get somebody out of bed for 24 hours.
I'm sorry, let me clarify that. You can get people out of bed. It was the really intensive protocol that she did about the frequency. Thank you, I didn't say that well enough. It's the frequency, how often, and doing the different activity. That really intense early rehab before 24 hours ended up in not better outcomes when they looked at death and some other measures on that. So that doesn't mean that you can't get somebody out of bed or move them if they're appropriate. It's just that intensive getting them up and moving them may not always be the best for the patient. And I don't think we really know. I was really surprised when Julie tweeted out something about AVERT Trial 2, and I thought, oh my gosh, because it was so much work the first time. But they have a lot of questions about some things are coming to as they're analyzing the data post hoc and looking at some of their secondary outcomes. From what I understand and talking with different people, is that they're thinking about there's something about that frequency and the intensity of what's being done. And they need to look a lot more closely at that, and I think they're working on that. And I think they might even have some abstracts. I've kind of lost a little bit of track here recently in the last few months on what they're doing, but I think you can still get people. We're not saying leave them in bed for the first 24 hours. We're saying you can get them up. It doesn't have to be that really intensive protocol that's been published or that we were initially thinking would actually result in better outcomes. Thank you.
Thanks.
Yep, I appreciate that. So I just want to share with you our submaximal exercise test. So again, we use the recumbent stepper, it's the new step. We use it because, again, a lot of patients early can use it. They can use their stronger side to help propel them. It's easy for them to use the seat swivel so that we can do easy transfers. We've had in our prior studies, we've reported on this, that people who can't use the bike were able to participate in exercise using the recumbent stepper device. And so again, it's really nice to be able to use this. We didn't want to recreate a new protocol. So it's very well published, the YMCA protocol. It's a cycle protocol. We follow that test. And so what we do, we've modified it slightly because on the bike they start at 25 watts and the stepper doesn't go that low. So we had to start at 30 watts. And so again, if you're really fit on that first stage, your heart rate's going to be less than 80 beats per minute once we finish that first stage. And so you're going to jump from 30 to 125. So you have to be in really good shape. Now, I will tell you, if somebody's on a beta blocker, their heart rate can be that low. You should not put them at 125 watts. It's not going to work. So there has to be some clinical decision making on the behalf of the therapist or whoever's executing the test. Again, if you know they're fatigued, you might start here or here. And again, I like it because you get a physiologic response. You're looking at something that they can't change or manipulate. It is their heart rate response to their activity. And then regardless of what their heart rate is, they stay in this track, whatever track it is. So again, if their heart rate at the end of that 3 minutes of that 30 watts, they'll go to 50 watts, 75 watts, and then 100, or whatever they can go. So for most of our stroke patients, they finish somewhere right around in this area. We've had only a few people get to 75 watts. So if we get to the argument of time, you have 3 minutes here. Most people stop at either at the end or before. You have, you have your 6 minutes, and a few people go here. So again, the argument of time, I'm trying to give a little bit of pushback on that. So I'm just going to run through this fairly quickly because I want to make sure we get to the rest of the data. But when we developed this, we tested it in healthy young adults first and actually measured their peak VO2 and used our protocol to estimate their VO2. And you can see this really nice fit. It's nice and tight. So we were really comfortable with that. Well, we said, well, runners and these these healthy people aren't going to use this recumbent device. They're just not. They're going to run or use the bike. So we said, who's really going to use this? And it's older adults. When I worked at the skilled nursing facility, they would fight over the device because they all like it. They can get on. It's real comfortable. So we said, let's test people 60 to 80 years of age. We just welcomed anybody from the community. So we had multiple comorbid conditions. We had stroke, knee osteoarthritis, cholesterol, thyroid issues, diabetes, but they were community ambulators. So we used the exact same prediction equation, and we did a max test on them to get their actual and measured. And again, we estimated it, and we still had a nice fit, and we were comfortable enough for this to move forward, to move it into stroke. We have published data already that when we looked at our test and also measured their VO2 peak, we had a really nice correlation. It's not as tight as the young individuals, but I think that's because the younger individuals and some of these older individuals were really motivated and they gave us a really good test. But we were really happy. It's better than a lot of tests that are published in the literature. But here's where it was fun. We actually did the reliability of this test in the inpatient unit over at the hospital. We recruited, stroke participants. First we did 50 participants who were healthy, and we had a really nice correlation. So then I said, well, it's probably not going to be as good in stroke patients. And so we looked at recruiting stroke patients, and we really thanked the hospital PTs and Dr. Varday for helping us recruit and identifying people. We consented 22, 20 completed both tests. We know that their fitness is low, but I was really surprised. Really, really surprised, because we had multiple testers, and we did that on purpose, and to have that good of correlation. Now, there were only a couple days in between it, so they may have remembered what we did, but still, they're tired, they're in rehab. We purposely did this in the inpatient rehab to see really how well could they perform. So again, I think this just gives us added justification for doing exercise and being able to conduct it in people post-stroke. So hopefully I've shared some evidence, and I just want to go over a few things here on why we really should care. We know that their fitness and stroke gets better. Their fitness, their overall health gets better. That alone should really be an important aspect for why we should think about fitness. There have been some studies that have looked at cognitive improvements, and again, if we can think about exercise for brain health, we've paired up, and I'll talk a lot more here shortly about our work with the KU Alzheimer's Disease Center. And really the benefit of exercise is to improve that vascular system to help with memory issues and cognition. Walking endurance. When we look at the 6-minute walk test, they get better. I'm not suggesting that their walking ability, so heel strike or motor control, gets better. I'm suggesting that their ability to walk further, to do community ambulation, gets longer. And for a lot of patients, that's really important. Do I get to play with my grandkids? Do I get to go to the park? Can I walk through Walmart versus using the scooter? Those things are really meaningful for people. We've seen a paper that suggests reduction in cardiovascular risk factors. We've done some work in vascular health where we use flow-mediated dilation as an outcome measure. Again, we place the cuff on their forearm, we're measuring the flexibility of the artery, and we've seen that get better. And then I think one of the newer and most exciting areas is the idea of neuroplasticity and motor learning. There's been some evidence suggesting that maybe exercise can be used as a primer. Dr. Laura Boyd, who used to be here and run our PhD program, now is at UBC in Vancouver, and she's really looking at the idea of using exercise, and a lot of people are really interested. Can we use it as a primer in rehabilitation to improve stroke recovery? And I think this is some exciting areas in which we might be able to pair the two together. So hopefully I've convinced you exercise is important. We need to think about it. I really do, as a profession of stroke recovery and stroke rehabilitation, we need to think about it. So when I've done all my vascular work, I've been sort of a neck down person, researcher. I've been interested in the femoral artery. I've done work in the brachial artery. And certainly looking at the carotid, but in 2012, I had a really well-known stroke neurologist over in Maryland, Rich Macco. He and I have done a lot of work with exercise, and we were having a conversation about the brain and recovery and vascular health. And he looked at me and he said, Sandy, he said, I really think you need to look at cerebrovascular health. I think that's going to be the way of the future. And I thought a lot about that. And how we could really get at that and what tools were being used, because again, I always go back to exercise. I think it's so important to look at with that heart-brain connection, that, and when you do MRI, you can't really get it exercise in the scanner. There's too much artifact. And so I started thinking about how we could do this, because I think it's really important. There's a strong link there. And of course, the heart's the better organ. I just want to make that clear as we go through. I love the brain, but the heart's the better organ. So when I started thinking about brain function, there was this paper that came out from, if you know Kazi DeCola, he does a lot of brain vascular work, and he believed in vascular health and cognition and Alzheimer's long before people were really acknowledging it. He's done work dating back to the early 90s on this, really advocating for these that Alzheimer's and some of this is vascular dementia, and it's really a vascular disease. And this really spoke to me. So we all start out at 100%, but if you look at this over time, our brain function declines. Now this is a hypothetical patient, a trajectory of what an Alzheimer's patient would look like. This is not a real patient, it's hypothetical. And he's suggesting that your vascular regulation declines earlier than your brain function. But if you look at this bottom line, the pink line, the neuropathology, it's really undetectable, and we see it start, but the age at which it intersects vascular health is a lot earlier than when it intersects the brain function decline. And I'm sure this is cognitive changes, early memory, MCI. And so I started thinking, if there's a way that we could really capture this, how can we really test this and look at it? So here's what I came up with for research and new opportunities and new frontiers and things that we can really think about to really answer some of these vascular questions and thinking about heart health for brain health. So we have this trial. So for some of you that have been here long enough, you may have known in 2013 I did this ridiculous idea, actually, in hindsight, of walking across the state of Kansas, all 570 miles. The goal was to educate on physical activity after stroke and why it's important. We did a lot of talks along the way. We paired up with the American Heart Association, but also, we paired it with a fundraiser to get this equipment. I didn't get funded on one of my rounds, and I knew it was going to be hard to really get a grant and also buy equipment, because they want to know that you can do the work before they fund you for it. So we made this fundraiser, and so the goal was to get transcranial Doppler ultrasound. Because I want to do it during exercise, we had to get these special probes that are robotic controlled, and then when it finds the signal, it actually locks on. I have a picture, we'll show it, and keeps the signal so that we can measure it during exercise, which is super cool. We also had to get a piece of equipment that allows for beat-to-beat blood pressure. We can't just get a blood pressure reading during exercise. We want beat-to-beat, because the blood flow is so closely linked with blood pressure. We needed to be able to look at those both together. And then we also measure CO2 output, and you'll see the setup here shortly. But we had this, but stemming from that 2004 DeCola paper, this project eventually got funded through the American Heart Association. But it's a collaboration with the KU Alzheimer's Disease Center and my lab. They're already characterizing their individuals, and Dr. Burns has an RO1 where they're scanning whether or not they have amyloid or not in their brain, and so why not take advantage of that? So we're leveraging his RO1, and we're doing our transcranial Doppler. We're doing it at rest and during exercise. And so our outcome measure is what we call CVRC, or cerebral vascular reserve capacity. And what it is we get their baseline measure, and then we look at them at exercise, and we look at this difference between them in both the amyloid elevated and the non-elevated. So here's our setup. So it's very complex. It really is. Here's the phenopress. We get beat to beat blood pressure. Here's the TCD. These are the special robotic probes, so it looks a little bit different than typical. We use EKG as the electrical activity is our trigger point. We know that once the electrical activity happens, we're going to get blood flow and also a pressure measure. And then you can see Sarah's happily donning the CO2 output and wearing her little cannula. So we have them start out sitting at rest, and then we have them exercise on the device, and they're using their legs only because they have to stay still during the exercise. So our preliminary findings, we have found group differences. We're working on a publication now between those that are elevated and non-elevated. They don't have the people with beta amyloid elevated don't have as great of a change in their blood flow. Now, we don't know about cerebral angiopathy or anything like that in these individuals, but we do know that they have amyloid in their brain. The KUADC also characterizes the load that they have across their brain. So again, in this study, we have more non-elevateds than we have elevateds. So you can see they're clustering here, but you can see the worse their amyloid load, the higher the load, the worse their brain, their vascular function is. And so this is actually going to be one of the first papers to take what's been done in amyloid and sort of show these findings and replicating. And we hope this has really profound implications for the way we could possibly look at this. So these are in 56 people. To date, we have 121 enrolled out of, and we have, I think, 124 scheduled. So again, just the recruitment that the ADC provides has just really been a joy to collaborate with them. But I started, when we look at them at exercise, and we look at them with at rest and then at exercise. And one of my DPT students who was funded by Dr. Nudo's T32 said, well, yeah, we have these differences, but when we look at the change, it's more meaningful than when we look at just exercise and rest. And I said, well, that's really interesting. So again, these fresh eyes came in and gave us some ideas. And so I started thinking about what's been done in oxygen uptake kinetics or muscle blood flow kinetics. And they've measured this. They look at rest, and at time zero, exercise begins, and then they track this. And I said, gosh, I wonder if we can even do this in the brain. I don't know. And we found out that we can. We can actually track this in the brain and look, and we see a very similar response. I didn't know how stable blood flow would be due to exercise or how big of a change, but we can now model that. So I contacted the author of this book, David Poole, and we formed a collaboration and decided to look at it. And we've just published our first paper on this in the Journal of Applied Physiology. So these black marks or dark circles are young, healthy adults. So you can see that they have this nice uptake in brain blood flow. These are older adult. So again, you can see that the change is a little bit more, there's a little more noise, but it doesn't change as much. And this is a stroke patient. This is a stroke patient at right about 3 months, so very little change. So then that spurs the next questions of, can we change that? Can we do an exercise intervention to improve their blood flow kinetics? Can we do that? So that's one stroke patient. So right now we're actually we are recruiting, we're working with Dr. Eichmeyer, who she's referred to, thank you, and Dr. Varday, we're working with them to try to get people right around that 3 months. So we're trying to connect with them. So if you're a resident and you're working with them and you want to help us, this is a great opportunity to do that. Recruiting stroke is a challenge, but we really believe that we have some exciting opportunities between physiatry and our lab. So if you need a little more convincing, so these were my prior DPT students who wore red for Heart Day, so I was very impressed by that. When we look at their baseline, so again, when we have a lot more data, when we look at baseline, you can see the difference in resting versus the older adults. There's just a difference in this blood flow. Much greater baseline than the older adults. Now, in fairness, probably a lot of these younger people a little more active because all the people we're testing are sedentary, or the majority of them were sedentary. And then here's the amplitude, which is that change. So if we're looking at the amplitude and we think about the change in that, that's what we're recording. So again, we can't expect big changes in blood flow in people because the brain doesn't like big changes. The brain doesn't want a big rush of blood flow. If we know from concussion and second impact syndrome that the brain really tries to regulate, it is very tightly regulated. But we do see differences in older adults when we think about this. So then we said, okay, well, when we look at that curve, of course there's going to be differences. But what if we recruit active older adults who are 65 and older, who are doing triathlons or exercise? What would we see? Would we see something different? And the hope is that we would. So this individual, I mean, just amazing. It's done over 100 marathons and runs all the time, very active individual. So we brought him in. He was very happy. We brought in a lot of people, and we compared him to our sedentary group. And again, if you look at these baseline measures, we do see that there are differences in their baseline measures. There are some slight differences, not as great as I thought, but again, there's this. We have to understand aging and how the blood flow changes with age. So there are differences. The sample size was 6 and 4. We split this, and so again, we don't have significant differences. But again, we're seeing these trends. So this is really encouraging for when we think about exercise for brain health, exercise for stroke recovery. Is just, I think it's really a neat opportunity to really get some novel information. So again, some future directions and things that we want to look at is, can exercise change the MCAV, which is the middle cerebral artery velocity kinetics, and thinking going from baseline to a higher amplitude. We'd like to pair it with MRI and with imaging. You can see this picture here. They've looked at, here's what you are sitting. I guess this is your brain after sitting, and this is your brain after exercise. So again, there's some novel ways in which we can characterize this. We're currently recruiting, as I said, for stroke. I think this has huge impact for concussion. I really do believe that if we could look, at changes in blood flow with concussion, that this could be meaningful, especially return to play where they're going to do exercise and run on the field. I think it has some implication. And then heart transplant. Imagine, again, if you're not getting good blood flow to your organs, they deteriorate. And can we, if they had a heart transplant, would that brain blood flow improve so that they would maintain their cognitive ability a lot longer, which I think is important. So in summary, I think, I truly believe that healthcare providers, we need to talk with our patients regarding exercise and physical activity, especially in our clinical patients who have a lot of comorbid conditions. We really need to evaluate and prescribe exercise. I think we need to look at our healthcare professionals, the physical therapist who also is very well trained to do this, or credentialed clinical exercise physiologists, and can we bridge that gap from rehab to the community? I think that transition of care is really important. And exercise is very powerful medication. We need to be aware of that. It improves so many conditions. So it wouldn't be fair if I didn't thank my team. My lab team is just truly amazing with all the work that they do. They're the ones that are really doing all the testing and seeing all the participants and making sure that we're accommodating all of them. They're just really great. I need to thank Dr. Varday and Dr. Eichmeyer. As I said, stroke recruitment is very difficult, and we had some talks on how we can do this, and within a week we have already 3 people that we can contact. So again, if you're a resident working with them, we'd love to have your help. More eyes, the better. I definitely have to thank the KU ADC, Eric Vidoni and his recruitment core. They've been essential for Tracker, and Dr. Burns for allowing us to jump onto his R01. PhD students and the DPT students working in my lab. I've always had really tremendous students. And then May, who's in the back there, is my postdoc, so thank you. Certainly I don't have, our T32 listed, but they're certainly important for the PhD students and the DPT students I've had, and then all my funders. And then I'd like to really thank Dr. Nudo. I think through my years here, he's been very instrumental in my development, being my mentor on my K, and also really being supportive over time. So with that, I thank you. And don't forget, the brain, the brain comes along with the heart, and we got to think about vascular health for our patients. So with that, I'd be happy to take any questions that you might have. Yes, Dr. Mitra.
So that was a wonderful talk. Thank you. I was wondering if the effect of exercise is different in the type and severity of stroke. So specifically, it's ischemic versus hemorrhagic, and obviously severity. That is sometimes complex with permissive hypertension.
Right. So I think that. So are you asking about what we would see with our brain blood flow?
Mm-hmm.
So
outcomes after.
Right. So at the moment, we're starting with ischemic stroke. I think as everybody does, there's more of them. I think we'll look at hemorrhagic down the road. Right now, we're looking at, because we image or the MCA, that's where we're really targeting is the MCA. If they've had a stroke in the MCA or the downstream territories, they do have to be able to do the recumbent stepper. So if it's a very dense stroke and they can't pedal or be able to exercise, then they would not be included. So we're looking at people who are probably less physically affected because they need to be able to do the activities. I think we need to start there first. And look at that and see what types of patterns, because the ones that are less impaired, and I always, it's always hard because, the ones who have the more dense strokes who aren't moving as much really need these type of interventions, but we tend to start with those that we can mobilize and get around earlier. So we are starting with ischemic first. I think it would be very interesting to look at the influence of hemorrhagic. And then certainly the severity. We're documenting all that so we can do some secondary analyses, but we're trying to get pilot data so that we can go in for a bigger grant right now. But those are things that we're going to get critiqued on, we're going to get asked, and that actually came up within the initial review of our stroke RO3 was, small vessel disease versus a large MCA stroke is going to be very different, and you were correct in that. Yeah. Yes?
I don't know if you mind going back like 7 or 8
Nope.
slides to there's a graph with 3 plots on it, I think. There, that one?
Yes.
And just kind of looking at the bottom line and the pattern in the stroke affected patient, to kind of see that 60-second cycle. And I don't know if any thought was given to what contributed to that. In my mind, it just kind of made me wonder, in these stroke patients and you have the autonomic dysfunction, is there any thought given or any concern about, beta blockade and medications in these post-stroke patients? And if so, if any of that's taken into account, or if you think that is something that would need to be considered. And then I guess a comment to follow up on that is it would be interesting to see if long-term any of this information led to any change in like post-stroke recommendations that is affecting, cerebral blood flow in the future.
I think those are all great questions, and the more questions I get about this and questions like that just tells me I have, anybody wants to join and ask questions. I mean, we have a lot of work to do. And I didn't highlight, but we're really the first in the world to characterize this. Nobody's done this. People have looked at blood flow in different ways. And so there's differences when you look at, being in an MRI and you get the whole brain and you can look at where blood is going. We just get it in the MCA. So I just want to make sure that we all understand that. In the stroke patient, it is very interesting that we have that cyclical kind of pattern. Now, this is only one. We see typical patterns for the young, healthy that look like that. Some of the older adults are more responsive and some are less. So we're looking at their, whether they have heart disease, whether they're on medications for blood pressure, what their activity level is, because I think we'll have to do some secondary analysis. It's just so striking when you look at even just baseline. So if you look at prior to 0, this is their baseline, and looking at how these velocities change over time. And I would like to add that, when you look at these changes, when they've done this with medication or giving CO2, the change in overall global flow was actually very well matched by TCD. So TCD can be used as a surrogate. It's not global blood flow. But I think you're right to regulation, and that's why it's really important to look at that beat-to-beat blood pressure. So, Dr. Vidoni's also collaborating with us on this, and so he's taking some of his work from his dissertation where they looked at motor learning and kind of looking at pairing the stimulus with this response. So he's interested in, and he's actually run like a cross correlation that looks at blood pressure response and at how quickly and what the timing is of blood flow response. So it's almost a 1-to-1 match. So that regulation of blood pressure and their mean arterial pressure and how that you regulate that, I think really does affect blood flow. And I think, again, if we can look at this, and I think there'll be justification for, making sure that they are taking their meds. Again, can we do an exercise intervention that might change that? We could not acquire their contralateral MCA, so this is the ipsilateral MCA. So again, we need to look at both sides We need to, make sure we get both and then get more people in. Is this something that's unique to this person, or is this at 3 months post-stroke pretty standard? We're also bringing them in at 6 months. Do things change over time? So that's a really great question. Yeah. Yes, Dr. Furrow.
Probably a totally naive question, but if you try to increase blood flow in a vascular system that's already been compromised, is it ever the case that you would be concerned for aggravating additional problems in that, creating an aneurysm, having a secondary stroke based on the increased blood flow in a system that's already susceptible to a damage like that?
So that's a great question, and it's not naive. That's actually a really good question.
Didn't have anything to do with the year, so I figured I would ask.
No hearing. We haven't checked hearing. So I would say that looking at this is very important so that we know what exercise does. I'm not worried about doing what we're doing and causing any problems. The recommendations after stroke are to exercise. Now, there was this great paper that came out in 2015, and it was a review paper that was called something cause and consequence. I can't remember what it was, the neurological, but it's really about we're prescribing high-intensity interval training for people after stroke, and where you really have rapid changes in blood pressure, and that will follow blood flow. And they're saying, we don't know, we're just adapting this. Where sometimes in rehab we're quick adapters. Oh, everybody, we need to do this in stroke. We've had good results. And so they really criticize the groups that are already doing high-intensity interval training in stroke without knowing what it does to the brain. If the regulation system works okay, I don't think we'll see these big, we won't see big increases for what we're doing. We do a low intensity and we do a moderate intensity, and it's all been well tolerated across that. But you're right, we don't know, and that's why we need to look at what's the blood pressure response, what's the blood flow response, and is it a normal? I would just hate to be able to say that exercise is not good and we shouldn't do this. So, I'm hoping that that's not where, that's not the message that we're going to end up sending. But I think the question is that you're right, they have a compromised system. Can we do exercise to help that improve? And maybe it's a blood pressure regulation issue.
Have you had any patients that have had untoward effects after the exercise, like increased stroke risk or anything like that?
We haven't had any. Our young healthy are fine to do this. Our older adults, they are 65 to 85. We certainly monitor them. We've never had anybody call us back. Like I said, for the study tracker, we've almost completed 125 people, and we've had nobody report any adverse events. The study we call ASSERT. And so what we're looking at is the change. And again, we've got 61 people that have gone through it total, and we haven't had anybody report it yet. But it will be interesting in stroke, and that's something that we'll have to look at. Now, we do ask, just from a safety, Dr. Verde and Dr. Eichmeyer have to say that they're okay and that they're stable to do exercise. It's their clinical judgment. But what happens between their discharge and when we bring them in 3 months, it's anybody's guess. Dr. Nudo?
To have this really unique perspective on peripheral blood flow, what are your thoughts now as you're entering into these kinds of studies, whether this is a general cerebrovascular change with aging and with neurological disorders and changes in velocity or oxygen kinetics, and whether there's some specific decoupling with cerebrovascular hemodynamics.
So, and is the question, you're wondering what happens in the periphery or just?
Yeah, is this I don't want to say merely, but does this parallel closely the peripheral blood flow changes? And if so, it may be easier to look at those blood flow changes in the periphery. It would be a surrogate for what's happening in the brain. Or is there something different that happens in the brain?
So I have two thoughts on that. I think that the brain blood flow is not as responsive as muscle blood flow. If you look at the femoral, it's hard because it's a bigger artery, but if you get down into the microcirculation where you are in the arterial level, the change in diameter is so great there that it's a little bit, it can accommodate more blood flow. The brain doesn't, the brain really likes to be stable. And we've seen this in, I've talked to some people that have done imaging studies pre-post, and they look at resting, and they're like, well, we did all this and we're not finding any change. And I said, well, the brain doesn't want to change. It wants stability at rest. If you think about what the heart does, and again, it always goes back to the heart, but when you look at cardiac output, it wants to maintain stability, and so it does that. If you increase your stroke volume, your heart rate goes down when you exercise. If your stroke volume decreases, your heart rate's going to go up to maintain that stability. So the brain likes stability. There are differences between what we do in the MCA and what's been done in the legs. So if you look at this graph right here, you see a much sharper rise in blood flow. And the reason is that they're taking them to a near maximal effort. So they have them strapped into like a biodex, and they're having them hurry up and kick, or they're doing hand squeezing right here. So they could go all out, and they get this sharp rise in blood flow. We can't do that, and this is a limitation to our methodology, and I don't know how to overcome it. But when you have them push and pull, you have to be really careful that you don't get a lot of noise. Because the MCA is so sensitive to blood flow, or to blood pressure, we have to be really careful. If they Valsalva, their blood pressure drops because intrathoracic pressure drops, blood flow drops. And so we have to, if you notice, our slope is a little more blunted and the rise is a lot slower, and that's because every 10 seconds we have to increase. Everybody gets to their targeted heart rate in 30 seconds. So when they do it in the muscle, they go much faster. So we're seeing differences in how we have to execute that. And so that is a little different. But you're right. I don't know that it can be a perfect match unless we looked at muscle blood flow in this way. I think the changes in pressure, the match between MCA velocity and pressure are so unique to the brain that I think that it really does have implications. I would expect, and I think about this in concussion, because these young kids who are playing, their blood pressure should be fine, and I think they can regulate it. Because the cerebrovascular system can auto-regulate, and it makes changes based on feedback within the brain. It can vasoconstrict when maybe the periphery isn't, or it can dilate due to changes in the brain, due to those chemicals, due to that impact. Again, if we saw changes in TCD, irrespective of blood pressure, I think we could find some really interesting results just because of that relationship.
Well, thank you very much for a wonderful
Thank you.